Have you ever been part of a team or maybe seen an organization that just wasn't performing like you thought it should? Despite having all the right pieces. I mean, the perfect team on paper, maybe top-notch equipment, a decent budget, policies all written down nice and clear, everything looks right, but it still felt like something crucial was missing, like it just wasn't quite clicking. Well, today's deep dive might just shed some light on that, especially when we talk about really complex systems like healthcare. We're going to dive into a pretty fascinating way of thinking about these systems using an analogy you probably already know, hardware and software. And our exploration today, it's based on a really significant scoping review. It was published in Health Policy and Planning by Nicola and Lucy Gilson. They took a deep look at how this whole hardware-software idea has been used in health policy and systems research just over the last decade or so, and honestly, their findings are quite illuminating. So our mission today, let's unpack what health system software actually means, why it's so important, and what the research is telling us about how it's being studied. And maybe, more importantly, how it needs to be studied more deeply. We're going to try and pull out the key insights for you, help you maybe see these systems in a whole new way. Okay, so let's start with the basics then. When we typically think about health systems, our minds often jump to the tangible stuff, right? The hospitals, the medical equipment, the budgets, the formal policies written down somewhere. This review calls all those things the hardware of a health system, which, yeah, makes sense. It's the structure you can see.
Exactly. And what's really compelling here is how the review then brings in this idea of software. And it defines it as the less visible elements, but the ones that are profoundly influential. They underpin relationships, they guide actions within the system. Think about things like processes, deeply held values, social norms, different ideas floating around, interests, power dynamics, and just that whole intricate web of human relationships. It's the invisible force, really, that makes the system tick, or sometimes keeps it from ticking properly.
Okay, so if I'm getting this right, it's not just about what you can see, like that shiny new MRI machine or the latest policy document. It's also about these often unseen forces that dictate how things actually function or, stop them from functioning well. And this way of thinking, it helps us see health systems as these complex adaptive systems, or Cs, is that the idea? Highlighting how dynamic and interconnected they are.
That's absolutely the idea. It shifts us away from just looking for simple fixes to understanding these dynamic interactions. And the review goes further, actually. It distinguishes software into tangible forms and intangible forms. So tangible software could be things like formal processes, knowledge, specific skills people have. But then there's intangible software, things like values, norms, the overall culture of an organization. There was a paper, for example, by Eric Hellion and colleagues that looked at governance. They pointed out how governance has tangible bits like committees and guidelines. You could maybe call that hardware or tangible software, depending on the framework. But it also has these really important intangible features like power relations and social hierarchies within that same structure. It's a much more nuanced view. Older ways of thinking might just label governance as hardware and leave it at that.
Right, that makes sense. It's layered. And I was actually surprised by some examples they mentioned. There was one paper, I think by Davis and others, that defined levels of maternal education as a form of software. That really struck me. It points to how these broader, sometimes invisible, contextual things can really shape how health systems work on the ground. It's not just internal factors, is it?
Precisely. It's the whole context. And, well, this brings up a really important question. Why this specific focus on software now?
Yeah.
Because the review highlights that historically, health policy and systems research often neglected these software components. For a long time, the focus tended to be much more on the tangible hardware, buildings, equipment, things you can easily count and measure.
Yeah, that kind of makes practical sense, focusing on what's easy to measure. But was there maybe a deeper reason, like a philosophical one, why the software side got overlooked for so long?
Oh, definitely.
Yeah.
The source material points to a few things. Practical factors, absolutely, like a focus on short-term needs, maybe donor interest, looking for those easily measurable returns on investment.
Yeah.
Hardware delivers that, right?
Yeah.
But yes, there was also this dominance of what's called a positivist paradigm in a lot of health research.
Ah.
Yeah, and this paradigm, it often sees health systems as just, vehicles for delivering technological fixes.
Yeah.
It doesn't always fully acknowledge that they're deeply embedded in complex political and social contexts with all these underlying power structures and interdependencies.
Like trying to fix buggy software by just buying a faster computer.
Exactly, you're ignoring the underlying code. And a really critical point, which Sheikh and colleagues pointed out back in 2011, was simply a lack of clarity. People didn't have a clear, shared understanding of what software even was, and if you can't define it clearly, well, it's incredibly hard to study properly. So after the first global symposium on health systems research in 2010, there were several really influential papers published in 2011, and they specifically called for more research into the social dimension, into really developing the theory around health system software. This review we're discussing today, it's basically a direct response to that call. It's taking stock, looking at what's been done in the decades since.
Okay, so they looked at quite a few papers, 112, published since 2011, that specifically mentioned health system software. What did they find? How were researchers actually using this idea?
Well, the analysis showed something quite interesting. It fell into three main patterns of use. And honestly, a pretty significant chunk of it was, well, surprisingly superficial. Yeah, about 38% over a third just used the concept almost like a hat tip. Acknowledging its importance, often just mentioning it in the intro or background section. Like, there was a paper on social accountability in Zambia. They briefly mentioned norms as health system software. It sort of validated their topic choice, but they didn't really use the concept in their analysis or design.
Just a nod, basically.
Pretty much. Then, about a quarter of the papers, 27%, used the concept a bit more actively. They used it to justify why they were focusing on a particular phenomenon. They'd explicitly define something like staff motivation or power dynamics or organizational culture as a software element they were investigating. This gave us some really useful concrete examples of what people consider software.
Okay, so that's more specific.
Yes. And then the final group, about 36%, used the concept even more actively. They used it to investigate broader health system experiences, things like preparedness or resilience or governance. And in these studies, the whole hardware-software idea often directly informed their research design. It became more of a core part of how they approached the study.
Right, so we see the spectrum from just mentioning it to defining specific bits to actually letting it shape the research. But what about those studies that really embraced it? The ones where it wasn't just a background concept, but actively guided how they did the research. That sounds like where the interesting stuff happens.
Absolutely. And the review did zoom in on those. They identified 18 papers that specifically, purposefully used the hardware-software conceptualization to inform their study design. And looking closely at those 18 revealed two distinct patterns of active use, really integrating it. So the first pattern, which included 42 of the 18 papers, was using the concept basically as an analytical framework. They use it to categorize and code their findings, especially qualitative data, looking at influences on different health system experiences, sort of like putting on hardware-software glasses to analyze what they saw.
Okay, so using it to sort the data afterwards.
Yeah. For example, Zwama and colleagues, they were mapping influences on TB program implementation in low and middle-income countries. They use hardware-software categories to code all these influences, including looking at interactions between them. And they concluded that software, things like workplace values, staff attitudes, was absolutely crucial.
Makes sense.
Another one, Mwamba and colleagues looked at why patients were disengaging from HIV treatment in Zambia. They categorized the reasons as hardware or software. And they found, and this is a direct quote basically, that hardware resourcing and software, clinic operating practices, including work norms and patterns and healthcare worker attitudes, often interacted and amalgamated to influence patients' decisions. So you see the interaction popping up there.
Interaction seems key.
It really is. Then there was McLennan and colleagues looking at Fiji's health system during COVID. They categorized things as tangible hardware, tangible software, or intangible software. And they highlighted these intangible resources like adaptive practices and what they call communal cultural values that really helped the system cope. Things you can't easily measure but were vital. And one more, Kagwanja and colleagues studied everyday resilience in Kenya. They used the hardware-software idea to frame the stressors the system faced. So, hardware stressors like resource shortages, infrastructure problems, and software stressors like low staff motivation or political interference. It helped them understand the different challenges.
That's a useful way to frame problems. Okay, so that was the first pattern, using it as a coding framework. What was the second?
The second pattern, seen in 6 papers, was a bit different. They used the concept more deductively. They drew on previous research to actually predetermine which specific hardware and software elements they were going to investigate right from the start.
So deciding beforehand what to look for based on the theory.
Exactly. For instance, Top and colleagues looked at rolling out universal test and treat HIV services in prisons in South Africa and Zambia. Based on earlier work, they decided up front to investigate factors like the willingness of different actors, software, resourcing levels, hardware, and the logistical systems. A mix, maybe. Musalman co-authors studied Lebanon's COVID-19 preparedness. They specifically looked at hardware and software elements, things like surveillance, infrastructure, workforce, but also communication, trust, governance, which an earlier review had already flagged as important for preparedness.
Building on previous knowledge.
Precisely. And Zawolo and colleagues studying community health worker motivation in Liberia used an existing framework by Koch and others. That framework helped them know which software elements like supervision or community trust were likely important to investigate.
Got it. And didn't you mention something about managers using this? That wasn't strictly research design, right?
Oh yeah, there was a fascinating side note from a paper by Nzinga and colleagues. They found that health managers who had actually been trained on complex systems thinking, including this hardware-software distinction, were really enthusiastic about it. They even reported using this understanding during nurses' strikes, appealing directly to the nurses' professional values, which is pure intangible software, to try and motivate them.
Wow, that's theory hitting the ground running. That's a powerful example of applying this thinking. And that Nzinga example and the Mwamba one you mentioned, they both bring up interaction again. This whole hardware-software idea, it feels like it really comes alive when you think about how they influence each other, right? It can't just be a list of parts.
You've hit on probably the most crucial finding of the review, actually.
Oh, really?
Yes, because despite the importance of interaction and complex systems thinking, the review found that out of those 18 papers that actively used the concept in their design, only 5 explicitly investigated the interactions between hardware and software.
Only 5 out of 18. That seems low.
It is surprisingly low. Most of them just describe the influences as separate hardware or software elements. They didn't really explore how a lack of resources, hardware, might affect staff morale, software, or how poor communication processes, software, might lead to equipment misuse, hardware.
Which feels like missing a huge part of the picture in a complex system.
Exactly, because interactions are fundamental to how complex adaptive systems work. It's like describing all the ingredients for a cake but never explaining how they combine when you bake it. But those few studies that did look at interaction gave us some really strong examples. Remember Dawes and colleagues studying performing out data manipulation in India?
Yeah.
They showed it wasn't just one thing. It emerged from this dynamic interplay between deficient hardware, a specific type of accountability system, tangible software, and an organizational culture that sort of validated cutting corners, intangible software. See how they fed each other?
Right, a perfect storm created by the interactions.
Precisely. And Top and colleagues back in 2015 working in Zambia found that, and I'm paraphrasing slightly here, structural staff shortages, the hardware problem, led to a high workload and pressure to rush, which is a software problem.
Right.
And that pressure, sometimes combined with lack of capacity, contributed to data errors or people just skipping tasks altogether. A clear chain reaction from hardware to software to outcome.
You can really see the links there.
Absolutely.
Oh.
And maybe the most explicit example was from Eric Killian and colleagues, the ones looking at TB infection control in South Africa. They actually used a concept map, a diagram, to visually show the complex interactions. They mapped out how high staff workload software impacted the efficiency of the patient file retrieval system, hardware, which in turn affected patient waiting times and flow outcomes.
A visual map, that's powerful. It helps you see the whole system.
It really does. It powerfully demonstrates how interdependent all these elements truly are.
Okay, so pulling this all together,
Well,
what are the big takeaways? For researchers listening, it sounds like there's a very clear call to action, right?
oh, absolutely. The review is unambiguous. We need more research that really deepens our understanding of health system software. And that means a couple of things. First, being really clear about which software dimensions you're focusing on. Use the examples we've talked about, values, norms, power, trust. But maybe also explore some relatively neglected ones. Things like gender dynamics, cultural competencies, maybe attitudes towards risk, different types of authority, hierarchy. These are often lurking in the background.
And beyond just identifying them, it sounds like the review suggests actually using the hardware-software idea as a tool during the analysis phase, like that coding framework approach.
Exactly. Using it as a coding framework not only helps bring conceptual clarity to often messy qualitative data, but it also adds rigor to the research. It helps ensure you're systematically considering both tangible and intangible influences.
Makes sense.
But the biggest gap, the most important call, is for future research to explicitly, intentionally investigate the interactions between hardware and software. Just describing them side by side isn't enough. We need to understand how they shape each other. Depicting these relationships, maybe visually like Eric Killian did, is absolutely vital if we want to truly grasp health systems as complex, adaptive systems. We need to see the dance, not just the individual dancers.
That's a great way to put it. Now, this isn't just academic navel-gazing, right? There are real implications here. So what can you, the listener, take away from this if you're working in a health system or, frankly, any complex organization?
That's a key point. This is definitely not just for researchers. The review highlights that simply being aware of this software dimension can offer really practical, actionable insights. Managers, leaders, anyone working within these systems, if you become more aware of the underlying software, the values, the biases, the hidden power dynamics, the unwritten rules, you can start to understand the organizational dynamics much better. And potentially you can find ways to sort of rewire behaviors or processes more effectively.
Up that example with the managers and the nurses during the strike.
Exactly. That Nzinga paper showed managers consciously using their awareness of software, the nurses' values, to try and motivate them in a really difficult situation. That's leveraging software understanding for practical leadership. And even more broadly, think about clinical practice. Began pointed this out years ago. Physicians need self-awareness about their own biases and their position in power relations. These are intangible software features of the interaction. Understanding these less visible elements, both in the system and within ourselves, empowers leaders and individuals to navigate complex situations much more effectively. It helps drive change that actually sticks beyond just, buying new equipment or writing another policy.
Yeah, this whole deep dive into health system software, it really does shift how you look at the inner workings of any big, complicated system, doesn't it? It pushes us beyond just looking at the visible hardware, the structures, the resources, to really consider this crucial, often hidden software that genuinely shapes what happens. It's like realizing the system's operating code is just as important as its physical parts.
I think that's spot on. And if you connect this to the bigger picture, it really underscores that meaningful, sustainable change. It often lies not just in getting new buildings or a bigger budget, it's about understanding and sometimes needing to influence the beliefs, the relationships, the norms, the unwritten rules that govern how people actually behave day to day. It's about potentially changing the system's underlying code, its operating system.
So thinking about everything we've discussed, here's something to mull over. How might you apply this hardware-software lens? Maybe not just in healthcare, but in other complex systems you're part of, or even just the dynamics within your own team or organization. What software elements those values, norms, relationships, power dynamics might be driving things, for better or for worse, that maybe you haven't fully considered yet?